Good evening, everybody. Thank you for taking the time out of your day and choosing to participate in this session of Healthy Woman Community Talk. January is actually Cervical Cancer Awareness Month, so aptly our topic today is on cervical cancer. We'll go over cervical cancer basics, how it can be detected early and prevented. But before we go into all of that, I just want to take a brief moment and have us all just imagine a world where we did not have to actually have this talk because cervical cancer simply didn't exist.
In 2018, over 300,000 lives were lost to cervical cancer, and the problem could soon be much worse. But right now, we can come together to eliminate this cancer for good. If by 2030, we can have 90% of girls vaccinated, 70% of women screened for early signs of cancer, and 90% of patients receiving treatment, in the coming years, we can save millions of women's lives. Each one a daughter, a partner, a mother, a friend. Together, we can create a cervical cancer-free future.
The World Health Organization, or WHO, is, as you saw in the video, working toward global elimination of cervical cancer. And this is possible because cervical cancer is one of the only cancers where we have an effective screening test and a vaccine for prevention. In 2020, the United States, along with 193 other countries, committed to WHO's 90-70-90 strategy to eliminate cervical cancer. So getting 90% of girls fully vaccinated with the HPV vaccine by the age of 15, making sure 70% of women are screened for cervical cancer, and then ensuring that 90% of women identified with cervical cancer are actually treated. So to me, it's unclear if this will actually happen by 2030, though one can hope. But elimination of cervical cancer is a reality that can happen in our lifetime. And it starts with me, you, and our communities. So with that vision in mind, I wanted us to now jump into and discuss some of the basics about cervical cancer. So let's start off with what exactly is the cervix. So I'm going to just go over a quick tutorial of the female pelvis. So this portion here in the middle is the uterus, and the tubes extending from it are fallopian tubes, so there's two on each side, and similarly there's two ovaries. And then the vagina is down here. The vulva is the soft tissue that leads into the vagina. So as you can see in the diagram, the cervix is the lowest portion of the uterus, which looks like a neck or a narrow canal. It connects the body of the uterus to the vagina. The word cervix is actually shortened from the Latin cervix uteri, which means neck of the uterus. So that makes sense. The way that we look at the cervix is with a speculum, which can either be a metal instrument, which is what's pictured here, or it can be plastic. So when you go to your doctor's office and they say they're going to do a pelvic exam, what they're doing is most likely a speculum exam to take a look at the cervix. So the view that they see is this. This is an image of a very normal appearing cervix. The cervix has an opening here, which is depicted by the arrow, and that leads into the uterus. This is a diagram of a cervix that clearly has abnormal tissue on top of it. It's irregular appearing, and so that's definitely worrisome for cancer. So what is the incidence of cervical cancer? Cervical cancer is a cancer that disproportionately affects developing countries. And so in the world, it is the fourth most common cancer in women, with about 350,000 deaths a year. And it's actually the #1 cause of death from cancer in women in 37 low and middle income countries that are located in sub-Saharan Africa, Central America, and Southeast Asia. However, in the United States, the incidence of cervical cancer is significantly lower, and that's thanks to the uptake of screening as well as the availability of the HPV vaccine. And so as you can see here, these are the 2026 estimated new cancer cases in the United States. Cervical cancer is down here with a 1.3% incidence when you compare it to other cancers in females. And when we look at U.S. cancer deaths estimated for 2026, it's also similar, comprising of about 1.5%. And a lot of this, as I alluded to, is really because of the uptake of the Pap test screening. And so it was first reported in the 1920s. Efficacy was proved in the 1940s. And so over the years, from 1940 all the way to the 2000s, the total cancer-related deaths from cervical cancer has declined by more than 80% because of this life-saving test. Interestingly, in 2024, so about 2 years ago, the American Cancer Society actually published data that for cancers, which there are screening tests, they are on the rise. And so the incidence of cervical cancer is rising in women aged 30 to 44. And these rates have increased by almost 2% each year since 2012. This is in contrast to younger women ages 20 to 24, where the rates have declined about 11% each year, and the thought that this is likely reflecting the first signs of cancer prevention from HPV vaccination. So what is this HPV that I've been discussing and mentioning, and why do we care about HPV? So HPV stands for the human papilloma virus, and 99%, so essentially all cervical cancer are caused by the high-risk HPV infection. So there's a lot of different strains, but essentially all cervical cancer is caused by high-risk strains. And the important thing to realize is that HPV not only affects women. First off, it is associated with 5 other cancers besides cervical cancer, and so it's associated with head and neck, or also known as oropharyngeal cancer. It's associated with vulvar cancer, vaginal cancer, anal cancer, as well as penile cancer. And it's also associated with genital warts. Globally, the most common HPV-related cancer is cervical cancer. However, in the United States, as of about 2010, head and neck cancer has surpassed cervical cancer as the most common HPV-related cancer. And so that speaks a lot to the importance of preventing HPV-related cancers with the vaccine. So one common misconception is the thought that HPV isn't that common or only affects people with multiple partners, so I don't need to worry about the HPV vaccine or HPV test. The truth is that HPV is common. So I oftentimes, when I talk to people about HPV, I really describe it as the common cold. 80% of sexually active patients will have had HPV infection by the age of 50. So pretty much if you're sexually active, you probably have had this infection at some point in your life. There are more than 200 types of HPV, but the good news is that the majority of these infections are low risk, and if we have robust and healthy immune systems, our bodies are able to clear it without any issues. Another common misconception that I hear is that if you have HPV, that means you will automatically get cervical cancer, and that's not true. So as I mentioned, there's more than 200 strains of HPV, and not all of them cause trouble. And so, as I mentioned, most infections that are low risk, our bodies are able to clear within 2 years as long as we're healthy. And it's really the high-risk subtypes that are the ones that are associated with cervical cancer and the other cancers that I mentioned. It's important to also recognize that with HPV infection with these high-risk subtypes, that these infections tend to be latent or dormant. So you can have the infection, and if it stays in your body and your body does not fully clear it, it actually, from precancer to development of cancer, the natural course takes about 10 to 20 years. So it's a long time for cancer to actually develop from precancer or dysplasia. And so what this means is that this allows a lot of time for the detection of HPV and precancer early on through screening tests. And then some risk factors for having a prolonged infection or the inability to clear these high-risk infections would be if you're immunosuppressed, so HIV infection, if you've had a transplant, or if you're a smoker. So I've kind of alluded to screening. Screening is important, again, because HPV infection and precancer is usually asymptomatic. And so when you have abnormal lesions on your cervix or even early cervical cancer, you may not have any symptoms at all. And so the only way to detect it early is through screening. And so screening is done through Pap tests as well as HPV testing. And so as I mentioned, getting a pelvic exam usually means having a speculum exam done. And then specifically, a Pap test means that a swab or a broom is used in order to sample the cervical tissue, particularly at the opening of the cervix, because that is where cervical cancer develops. I also want to clarify that especially, and I'll talk more about this, HPV testing is also done through a swab, so it's not a blood test, but it's actually done and tested through this swab as well. So what if I'm vaccinated against HPV? Do I actually still need Pap screening? And the answer is yes, and that's because although the vaccine protects against the majority of cervical cancer, so more than 90%, it doesn't cover all strains of HPV that can cause cancer. And if you were exposed to HPV prior to vaccination, so you got it after you became sexually active, you are still at risk for cervical cancer because of the prior exposure to HPV. And so getting screening is also important. So what is the actual frequency of Pap tests? I think there's a lot of confusion about this, particularly since the recommendations have changed and actually recently changed again. And so let's go over that. Current screening guidelines are that women who are younger than 21 do not need to be screened for cervical cancer with Pap tests. And this is regardless of the age of initiation of sexual activity. And that's because if you're younger than 21 and you are healthy, so you don't have HIV, or haven't had an organ transplant, that your body and immune system are able to clear the HPV infection without any issues. And we found that testing younger patients oftentimes results in greater interventions and tests that end up being unnecessary. If you're between the ages of 21 and 30, the Pap test alone, so not the HPV testing, Pap test alone should be done every 3 years. And then for women who are age 30 to 65, there's 3 different options, though this first one, the HPV testing alone every 5 years, is actually become now the preferred method of testing. And this is a very recent change in our national guidelines, as well as now endorsed by our federal government as well. And so what this means, again, HPV testing does still require a pelvic exam and getting that swab, but allows us to space out the testing to every 5 years instead of every 3 years, which, in my opinion, is very nice. Alternatively, you can also do Pap tests every 3 years, or you can also do co-testing, so HPV testing as well as the Pap test every 5 years. I think a common question that I get is, isn't it better just to get more frequent testing? Like, wouldn't it be better just to get an annual Pap every year? But what we've seen in our studies is that more frequent testing oftentimes results in more frequent tests and interventions that ultimately doesn't end up resulting in better outcomes. And so to try to avoid that, we've really spaced out the frequency of testing. And as I mentioned, cervical cancer typically develops slowly. From precancer to cancer, it takes about 10 to 20 years. And so getting screening every 3 to 5 years is adequate and would allow us to detect abnormalities early enough. So currently our guidelines are that once you are over the age of 65, you've had adequate screening history, so meaning that you have it, you've gotten the every 3 to 5 year testing, you have no prior history of any abnormalities, and you don't have other risk factors that actually Pap tests and HPV testing can be discontinued. I would say that this is somewhat controversial, and I am expecting that these guidelines may start shifting, particularly as our population ages and we have plenty of 65-year-olds that are very healthy, and we anticipate, we'll live 10, 20 more years. But at this time, the recommendation is to stop screening above the age of 65. So what if you go into your doctor's office and you end up getting an abnormal Pap test, or you test positive for a high-risk HPV strain? So typically the next step is for you to get what's called a colposcopy. And so what that is that in addition to the speculum exam where we take a look at the cervix, we use a colposcope, which is essentially a microscope where we magnify the surface of the cervix. We also place solution, including acetic acid, so essentially vinegar, onto the cervix, and that allows us to highlight abnormal cells on the cervix. And then if we see anything abnormal, then a biopsy will be taken. And this oftentimes is how we diagnose precancer as well as cancer. As I mentioned, early cervical cancer oftentimes is asymptomatic, and so this can be silent until advanced disease develops. Some potential signs of cervical cancer is bleeding after intercourse or bleeding in between your periods. If you have a foul, persistent vaginal discharge, any abnormal bleeding outside of monthly menses when you used to have that, pelvic pain, if you have swelling or pain in one leg, and that is because cervical cancer increases the risk of blood clots, and so that's one of the signs of a blood clot in the leg would be swelling in that leg. I'm only going to very briefly touch on cervical cancer staging and treatment. And so generally speaking with cancer, stage 1 means that it's confined to the organ in which it started in. So it means the cancer has not spread outside of the cervix. Stage 2 means that it's spread to the adjacent tissues, such as the top of the vagina. And then stage 3, again, is still confined to the pelvis, but we're seeing that it's spreading to the pelvic sidewall. You're seeing a picture of a kidney here because it can actually grow to such an extent that it blocks off the tubes that carry urine from the kidneys to the bladder, and so it can cause obstruction. And that can present as back pain, as well as recurrent bladder infections. This also includes spread to the lymph nodes, and then stage 4 is when you have distant spread. So you have spread to the lungs, for instance, also invasion into the bladder and rectum. And so depending on when cervical cancer is diagnosed, that also dictates the treatment. So if it's diagnosed early, oftentimes surgery is all that's needed. However, in these later stages, I would say radiation is oftentimes treatment, chemotherapy, particularly for stage 4. And there's a lot of data now for immunotherapy for treatment in late stage cervical cancer as well. So I don't know if I said this enough, but cervical cancer is preventable. And it's one of the only cancers where there's a vaccine to prevent it. And as I showed in the video at the beginning of this presentation, if we have a high enough vaccination rate, we can actually eradicate this cancer. And honestly, I would love to never treat cervical cancer again. So let's talk about the vaccine. FDA-approved HPV vaccines, there's been multiple iterations, but since 2016, Gardasil 9 is the only HPV vaccine that's now distributed in the United States. 9 means that it protects against 9 different strains of HPV. The first 2 are ones that are associated with genital warts, and the rest of them are high-risk strains associated with cancer. This vaccine is approved all the way down to the age of 9 in the United States. The CDC currently recommends that everyone the ages of 11 to 12 be vaccinated. And thankfully, with our current administration, although they did reduce the number of vaccines in our children, the HPV vaccine is actually still endorsed and recommended as a routine vaccine for those aged 11 to 12. There was actually recent guideline changes to potentially consider a 1-dose vaccine as opposed to the current recommendation for 2 to 3 doses. This is quite controversial, but I actually think this is probably a good step. There is very good data to suggest that 1-dose vaccination is as effective as 2 to 3 doses, particularly in children. And so I think hopefully this will mean a greater uptake of this vaccination, but we will see. And then the reason why it's recommended for children is because this really works best prior to exposure to HPV. And so the earlier you can get it, the better. All right, HPV vaccination. Let's talk about some common misconceptions. So the vaccine isn't safe or causes severe side effects. So the vaccine has been studied rigorously. It is very safe, and it continues to be extensively monitored. The most common side effects are very much similar to other vaccines, so local soreness of the arm or redness. Severe reactions are really rare, and there's really no proven link to infertility or other serious neurological conditions. Another question is, or thought is that it can transmit the virus or cause cancer itself. This vaccine does not actually contain any live virus, and it trains your immune system to recognize HPV, but does not actually transmit cervical cancer. It encourages sexual activity. I know when I got the vaccine, my parents had questions about it, along those lines. The vaccine, as I mentioned, is given before sexual activity to be the most effective. It's a standard immunization like others, and it really does not promote promiscuity. And it really, the purpose is to prevent future HPV exposure. And then, so it's not too late to get the vaccine if you're sexually active or older. Again, it works the best prior to exposure to HPV, but it is, insurance does cover the vaccination for adults up to age 45, and they still do benefit because it protects against the 9 strains, so you may not have been exposed to all 9 strains of the HPV vaccine. And it also has been demonstrated to help to prevent recurrence of precancer, even if you've had it before. Boys also should get it for numerous reasons. Again, it causes other cancers besides cervical cancer that also affect men. And by vaccinating boys and men, you're helping to decrease transmission of cervical cancer in the HPV strain. HPV, which could cause cervical cancer in women. And then I think I've talked a little bit about this, even with excellent screening, the screening is really to catch abnormalities that has already occurred because of the HPV virus. And so the vaccine is a step ahead of that, and to really prevent any abnormalities from occurring in the first place. So both are recommended. So what really has been the impact of the HPV vaccine? So since its introduction in 2006, we've seen an 80% decrease in cervical precancer. in 28 to 24-year-olds. And this is the age group that has most likely been vaccinated. The United States, I would say, is slowly improving on its vaccination rates. It, not surprisingly, dropped a little bit around COVID time, and unfortunately has stayed about stagnant since then. So we definitely still have work to do. But as of 2022, the U.S. average rate of vaccination in ages 13 to 17 was about 63%. And Wisconsin is about on par. We're a little bit behind. So if you look at, these are the national HPV vaccination rates, again, for ages 13 to 17. So for vaccine initiation, about 77% have been initiated with at least one dose, and for completion, it's about 60%. And in Wisconsin, again, this is a little bit of older data, but as of 2023, the initiation, about 64% have been initiated, and completion is about half of our adolescents. So what do we have to look forward to in the future, or actually maybe is actually happening right now? So single dose vaccine, as I mentioned, the current administration actually, at least based on their vaccine administration table, only lists a single dose of HPV vaccine, so that may be on the horizon. And again, I do think overall that will help to increase the uptake of the vaccine, or at least I hope so. Self-collection of HPV tests in office as well as at home. So I would say at UW, we are actually in the process. So we've integrated the primary HPV testing, so that every 5 years, just doing the HPV testing for those that are older than the age of 30. But we are also looking into rolling out potentially self-collection. So instead of doing the speculum exam and the swab that way, which honestly can be pretty uncomfortable, having patients do a swab with something that looks like a Q-tip, just placing in the vagina and swabbing themselves in the clinic. I do think in the future there's going to be at-home self-collection as well. The FDA approved a kit, I think sometime last year, and there's been federal recommendation to promote the self-collection of HPV tests as well. And then there's also up and coming real-time HPV testing, and so I think this is probably more significant for developing countries, but it really allows for the testing result to happen immediately, and then instead of patients having to travel long distances and coming back for treatment another time, you can treat them right then and there. All right, that concludes this presentation. I know that Cheryl had mentioned at the beginning of this talk, there was some questions that were emailed. I am happy to go through a couple of them, and if anybody else has questions, I'm also happy to answer those at this time. One of the questions that was submitted prior to today was regarding, actually these two questions are pretty similar, hormone replacement therapy and vaginal estrogen and how that affects cervical cancer. So cervical cancer is not known to be hormonally driven, and so hormone replacement therapy is not contraindicated. We don't think that it drives drives cervical cancer or is preventative. So there's not strong recommendations for or against it in regard to cervical cancer. Vaginal estrogen, similarly, I am a strong proponent of it for vaginal atrophy and just dryness, and it does not help to prevent cervical cancer, but it's also something that we know is safe to use even for patients who do have cervical cancer. Cheryl, are you still there? Can you hear me? Do you have a list of questions, or are you seeing questions in the chat?
Yes, I am. Yes, okay. I am. I'm going to start off with the first one.
Okay.
How important is extended genotyping? What are the thoughts or primary screening? On primary screening, I'm sorry.
Oh, okay. Um, so I'm not sure if somebody can, whoever wrote that question could clarify the benefit of extended genotyping, like of doing it right now or pushing to do it. So right now, when we do HPV testing, we're essentially screening for 16 and 18, which are known to cause 70% of cervical cancers. Additional subtyping, it doesn't really play into how, it doesn't change treatment, and so we typically don't do it. Um, and then in regard to primary HPV testing and kind of the transition to now that being kind of first line recommendation for screening, I do think it's moving in the right direction, especially understanding that the majority, if not all, cervical cancer is actually related and associated with HPV. And so if you carry that vaccine, or excuse me, that virus, that really increases your risk. So even if your pap test, for example, is normal, if you carry the high risk virus, it is something that we need to be monitoring people closer, um, and potentially doing colposcopies or more than just the pap test.
Okay, we have two more questions.
Mm-hmm.
Current 70-year-old tested HPV 16 positive in 2013. Colonoscopy showed inflammation, but no precancer.
Mm-hmm.
Normal PEPs over several years. HPV testing in 2024 was negative. For high risk HPV strains, 2024 PAP normal. How reliable is the HPV sampling testing? What do you recommend for future screening or follow up?
So I would say the HPV testing and collection is very reliable. And so from the history that you've described, to me, what it sounds like is at some point you did carry that, did carry the HPV virus, the high risk HPV virus, but then over time your body cleared it, as was evident with the most recent HPV test. And so that is reassuring. And so it sounds like the your provider did the right things and with follow up.
Okay, one more question. I had a hysterectomy with cervix removal at age 42.
Mm-hmm.
Do I no longer need testing since I don't have a cervix?
Yes, that's a great question. So it depends on if you have previously had abnormal pap tests or HPV testing. And so if you have not, and you've previously had screening, then no. Since you had a hysterectomy and your cervix is also removed, you do not need any additional cervical cancer screening. But if you have had previous abnormal pap tests, depending on when that happened, you may still want to talk to your provider, or at least ask if that's something that you should. So obviously, without a cervix, we won't be screening the cervix, but you may be at risk of precancer of the top of the vagina, and so that's something that you may want to be asking your provider about if you've previously had HPV positive test, or prior dysplasia or precancer of the cervix before your hysterectomy.
Okay, I'm gonna go back because we have a few more minutes left, Dr. Zhang,
Sure.
if you don't mind.
Yeah.
I'm gonna go back to some of the questions that came in on registration.
Sure. Yeah. Yeah.
One of them was, are Black and brown women more at risk for cervical cancer? Are women who have not had children at higher risk?
Yeah. So Black and brown women are not at higher risk of cervical cancer. However, I would say that it is true that we do see a greater percentage of advanced stage cervical cancer in Black women. And I do think a lot of that has to do with access issues with access, and not coming, obviously there's a lot of mistrust of the medical system, that are very much based in historical injustice. And so not coming in for screening, and then also, presenting later with cervical cancer. And so we definitely do see that, not only in the Black population, but also in Native Americans, I would say. That also is very much a population where we see a high percentage of cervical cancer. But I don't think it's biologic. I don't think it's because they are at higher risk, of getting cervical cancer. I think a lot of it is definitely can be remediated. A lot of it has to do with, us improving our outreach efforts, and trying to, yeah, just improve access to these populations.
Okay. Is there any harm or risk of harm in a woman in her 50s, 60s to get yearly PAPs? Waiting 3 to 5 years worries me.
Sure, yeah. I think that's not an uncommon thought. It's like, oh, isn't more frequent screening better? I would say that that's not recommended, mostly because, as I mentioned, if you're healthy, and even if you do say test positive for the HPV virus, your body most likely will clear it, in 2 years. And so what it ends up resulting in is that you have a positive test, and then inevitably you'll get more testing, more interventions, that doesn't really change the outcome because your body would have cleared this infection anyway. And so our studies really demonstrate that it is safe to space out the screenings every 3 to 5 years, and that is adequate time to catch early abnormalities of the cervix before it turns into cancer. Now, my only caveat with that is, these routine screenings is just screenings, right? So if you have symptoms that are abnormal, so for example, all of a sudden you notice bleeding after intercourse, you're having spotting, between your periods when that wasn't the case before, or you have other symptoms, you should go see your OBGYN or your primary care doctor and get a pelvic exam, because that could be a sign of something.
The question is, what is being done to overcome vaccine hesitancy to the HPV vaccine?
Yeah, I mean, I think, yeah, that's a tough question, right? Especially with what's happening currently with our administration, and the propagation of, just fear with vaccines. I mean, I think a lot of it is education. So even, thank you for coming to this session and listening. I think what we know is that if a doctor recommends the HPV vaccine, that significantly increases, the likelihood that somebody will get it. And so making sure that our primary care providers, our pediatricians feel comfortable talking about it, make sure that they are bringing it up to parents, in a way that, is comfortable, right? And then they can talk about it, without causing stigma. And so, that's kind of where the front lines is. And, I think I can't emphasize enough, just making sure that they are actually bringing it up and recommending it.
Another question was, what if we're married? Is the HPV vaccine still worth it?
Yes. So I would say, and I think I touched on this in one of my slides. It doesn't really matter. I mean, if you have more sexual partners, statistically, like, your risk of getting the HPV, higher risk HPV and different strains is higher, right? But if you're sexually active, period, you are being exposed to HPV. Like I said, the majority of us who are sexually active have been exposed to HPV and have had it at some point. And so because of that, you should get the HPV vaccine.
I'll do one more question.
Mm-hmm.
It says, does pap smears with past cultures that present positive, but after test proving negative, is that a precursor to cervical cancer?
Um, So if you have had a prior abnormal pap test, it means so there's a little bit of nuance to that, and so, so okay. In short, if you have had an abnormal pap test, that does not mean you've had precancer. We know that HPV can cause certain changes in the cervix, but not all of those changes will lead into cervical cancer. And so if it's a low grade change, oftentimes it's something that your body clears. And so that's not even considered a precancer. But if you've had high grade changes to the cervix, that's where we get more concerned. That's why we recommend closer surveillance and closer screening, because it's those high grade abnormalities of the cervix that can be detected with pap tests and HPV testing that can, over time, eventually lead into cervical cancer.
Thank you, Dr. Zhang.
Yeah.
Is there any more questions from anyone that they can put in the chat? And you're free to come off a mic if you would like to ask one without typing it in. Well, if not, I appreciate everyone being here this evening. Thank you, Dr. Zhang, for all your powerful information on cervical cancer. Um, if you guys have any more questions or any more thoughts, please refer to your doctor. And I'm going to give you guys back 15 minutes or so of your night. Have a good evening, and thank you, everyone, for coming.
Yes, thank you for everybody for your time and for listening, and hopefully you left learning something and feel more empowered to advocate for your own health as well as those around you.
And someone just asked, will the recording be available? Yes, it will. And then thank you for hosting. You're welcome, Lucretia. Take care.
Have a
Bye,
great night,
everybody.
everybody.